All right, I'm giving it a few seconds while people join, and then we will go ahead and get started. All right, hello everyone, and thanks for joining the Gaps in the Perioperative Revenue Cycle webinar. I'm Jordan Leibovitz, and I'm part of the marketing team here at IMO Health. A few housekeeping items before we begin. First off, this discussion is being fully recorded and will be available to you for later viewing. Be on the lookout at in your inbox, and we'll send it there. If you have any questions throughout this presentation, just type into the questions section on your Zoom control panel. Once our speakers wrap up, we'll do a Q&A. So take advantage of them. They're experts in this space. So that would be great. And then without further ado, I'm going to pass it on over to my lovely colleagues, Alex Brown. He is our product sales director, and my coworker, Shelly Jude. She is our director of global clinical services. So go ahead, Alex.
All right. Thank you, Jordan. So as Jordan mentioned, my name is Alex Brown. I am the product sales director here at IMO, overseeing our IMO Core Periop and IMO Core Procedure Solutions. Basically, I just work with organizations. I help them figure out what products are a good fit for them. I've been doing this now for almost 4 years. Prior to that, my background is in healthcare IT. I worked at Epic for a long time, and I also have a master's degree in biomedical engineering. So today we're going to be talking to you guys about a couple of different things, really trying to focus in on the revenue cycle and how the surgical scheduling dictionary impacts revenue cycle. For anybody who's not familiar with IMO Health, we are a clinical documentation and healthcare data enablement company that likely works with many of you in your current organizations with your current clinical terminology and code mappings. We have a major space in all of the big EHRs, and over 740,000 health professionals use us on a daily basis for ICD-10 codes, ICD-9 codes, SNOMED, CPT, HCPCS. We have over 5 million different terms that are all mapped to whatever code set is appropriate for that domain. And we're used at over 4,500 hospitals. Today, you're going to be hearing from me and Shelly. We are just 2 of the over 300 FTEs employed here by IMO. And we have just a huge amount of a variety of experience. As I mentioned before, my background is in engineering, but we also have terminologists, we have PhDs, we have doctors, we have nurses, nurse informaticists, really all the expertise you could want in this area. So kind of dive into it today. Why are we talking about this specifically? Why are we talking about surgical revenue cycle? And as I'm sure everybody on this call knows, surgical revenue cycle is one of the highest generating areas for most healthcare organizations. Typically, ORs generate about 60 to 70% of a hospital's revenue and also account for about 35 to 40% of costs. So what does that mean for us? Well, it means that anything we can do that helps bring a bit of efficiency inside of this space can have a major impact on the financial health of the organization. And so that's really what we look at. How can we do things that help optimize scheduling, improve workflows, make things a little bit more efficient down the entire stream inside of the EHR, the surgical EHR. So what we're really going to focus in today is the connection between the perioperative revenue cycle and the surgical dictionary. And to be able to start with that, I do want to make sure that we are all using the same definition of what a surgical dictionary is. When we're talking about a surgical dictionary, we're talking about the foundational reference list of all of your surgical procedures as recognized by your EHR and your revenue cycle systems. What that means is it's essentially the list of what procedures that you all perform as an organization likely and should be mapped. That clinical term should be mapped to the CPT and HCPCS codes and any other descriptors and modifiers so that you have the connection between the clinical language used by a surgeon, used by the nurses to describe the procedure and get that scheduled, and then, of course, the codes that you guys need in pre-authorization, scheduling, and billing. So really the idea behind that surgical dictionary is it's the shared source of truth, right? It's what everybody's using for ordering, scheduling, documentation, coding, and billing, what everybody should be able to reference so that when a procedure is being performed, everybody knows what's being done and what codes need to be pre-authorized and billed for it. So what we find oftentimes is many organizations inside their systems, these procedure lists can be broken. And when that happens, it really can create a lot of inefficiencies that we'll kind of dive into as we get through the presentation today. But that's really kind of what we're looking to focus in on. And with that, Shelly, I'm going to turn it over to you to kind of do the first part of the presentation, walk them through this, and then we'll go from there.
Hi, everyone. Again, I'm Shelly Jude. I'm the Director of Global Clinical Services. I've been in IMO 12 years, and I've been working on the IMO Core Periop product for 10 years. My background is in health information management. I'm going to go off camera while I present to make sure that I don't have any internet issues. Without standard, up-to-date procedure data, ORs can struggle to operate efficiently, ultimately impacting the bottom line. Operating rooms provide more than 70% of hospitals' revenue. At the same time, they are the largest cost center within most healthcare organizations. Because of this, there is an increased need to optimize workflows and time spent in the surgical suite when performing perioperative procedures. This is why underlying surgical procedure data is essential to scheduling accurately and optimizing OR time, preparing the OR and minimizing waste, and accurate billing and claims for optimal reimbursement. Next slide. Without standard data, ORs lose revenue, waste time, and face greater compliance risk. The impact of not having standardized and up-to-date procedure data can be significant to an organization based on the following industry information. Statistics show that there are an estimated 51.4 million surgical inpatient procedures completed in the United States annually. OR time is expensive within healthcare organizations. OR efficiency is key to profitability. OR efficiency requires significant coordination. Coordination and efficiency, in part, is a multidisciplinary function of surgical scheduling. Surgical documentation is critical to reimbursement and patient care. Along with these, you can see on the slide the impact. For example, denied claim write-offs for Medicare and patient-only claims average $16,000 per case. Wasted supplies on average $968 per case, and delayed starts contribute to inefficient use of OR time, with 45% of surgeries that do not start on time, to just mention a few. Next slide. Inaccurate, outdated procedure data leaves your perioperative revenue cycle vulnerable, and here are some areas and examples. Documentation gaps and billing errors and their impacts. Documentation gap examples: inconsistent and nonspecific procedure names, missing anatomical site, approach, or additional clinical context can contribute to incorrect CPT and HCPCS code selection, lack of adequate prior authorization, appropriate surgical room setup, time averaging, and documentation throughout. Billing error examples: inaccurate coding, so incorrect, there you go. Incorrect CPT and HCPCS codes, use of outdated codes, codes that do not match the service performed, and use of codes inclusive of another procedure being performed, so unbundling. Medicare and AMA guidelines establish specific rules and bundle codes for these situations, ensuring that practices adhere to appropriate coding practices. Example of unbundling: if a patient undergoes a laparoscopic cholecystectomy, the primary code for the surgery, CPT code 47562, often includes components like exploration and basic dissection. Separately coding these component services would be considered unbundling and could lead to claim denials. Compliance issues: inaccurate classification, ambulatory surgery center codes, and/or inpatient-only codes can lead to denied claims and revenue loss. What is inpatient-only procedures? Released by Medicare. Medicare identifies certain complex procedures as inpatient-only, meaning they typically require an inpatient hospital stay for patient safety and appropriate care. The compliance requirement for hospitals to be reimbursed by Medicare: procedures on the inpatient-only list must be performed in the inpatient setting. For reimbursement impact, Medicare will not pay hospitals for inpatient-only procedures performed outside of the inpatient setting. However, physicians performing the procedure in an outpatient setting may receive payment if medical necessity is documented. Also, lack of prior authorization for devices and supplies. Missed HCPCS codes for devices, high-end medications, implants, and catheters are just a few examples that can lead to significant revenue loss. prior authorization for hospital outpatient departments. Medicare mandates prior authorization processes for certain hospital outpatient department services to ensure medical necessity and payment. Scheduling workflow inefficiencies. Procedure names don't align with OR resource needs. The need for detailed clinical context and granularity of your procedure being performed is required for appropriate case durations and OR resources. Next slide. Maintaining the surgical dictionary is difficult. IMO Health assesses surgical procedure files and sees certain signs of poor data quality. For some examples, 5% of surgical procedure files have duplicate terms. 75% have terms with missing CPT codes, 48% of terms with no CPT codes, and 22% of terms with wrong CPT codes assigned. The assessment of the surgical procedure file is just one portion of the work that a group of IMO Health SMEs like myself do with the client. We typically pull together a multidisciplinary team that include project managers, OR case manager, scheduler, HIM team lead, coder, revenue cycle team lead, surgeon, OR nurse, and OpTime team member, reviewing their surgical dictionary assessment and workflows. Through this work together, IMO Health Core Periop offers standard naming convention throughout our terminology. And I'm able to assist our clients with identifying those opportunities to add missing CPT and HCPCS codes and update incorrect codes. In addition, with working through the impact of workflows for scheduling, prior authorization, inpatient-only coverage, and ambulatory surgery center code coverage as well, if applicable. Through all of these steps, the IMO Health SMEs are available to our core Periop clients as part of the team to ensure standardization and maintenance of your surgical dictionary and all of it encompasses. A few ways that IMO Health provides standardization and maintenance. We streamline the procedure naming. We encourage data governance. Tooling provides the ability to search for proper surgical name and code. We maintain HCPCS quarterly updates. We maintain CPT annual updates. We include up-to-date CMS inpatient-only data to prevent total loss denials. We include up-to-date CMS ambulatory surgery center excluded and covered data to prevent total loss denials. We offer an annual IMO AMA CPT updated webinar for continued education and training, and continued support from client success, customer support, HIM, and clinical SMEs. Slide. The surgical dictionary, your OR's operational anchor. Here we have concrete examples of how having an up-to-date surgical dictionary has helped some of our clients. For instance, a large health system with 7 hospitals saw an increase in patient estimates improve from 20 to 30% to around 90% in 6 months. Or another regional health system saw almost a 14% increase in case duration accuracy. Or another 12-hospital health system reduced inpatient-only denials by 57% and reclaimed $3 million in revenue. All of these are attributed to having a robust surgical dictionary. Now we're going to shift back to Alex.
Thank you, Shelley.
You're welcome.
So a lot of what Shelley's been trying to talk about today, or has been very successfully talking about today, is the connection between the CPT codes and the clinical terminology that's used to govern these surgical procedure lists. And so what I'm going to talk a bit about is IMO Core Periop. IMO Core Periop is our solution that helps organizations manage the surgical procedure list, ensure accurate CPT and HCPCS code mappings, but really with the idea that we know that these CPT and HCPCS codes are necessary inside of the surgical dictionary procedure list in order to create that connection so that can be used in pre-authorization, it can be used in billing workflows so that people aren't flying blind when it comes to those connections. If you think about the way many of your EHRs are likely set up, either your scheduler or your surgeon is starting your process off by selecting the appropriate clinical procedure. And when they select that appropriate clinical procedure, they may also have to select those codes. Depending on how your EHR is set up, that may be a required step. That may be a step that is not required, but that you rely on to get those codes. Or you may be having to go in and fill those in afterwards if that step is not input there at all. What we always want to make sure is that those codes are appropriate for the term. We also want to make sure that any sort of errors that this file could create are weeded out as early as possible, right? When that surgeon is going to place that order to start that case, we want them to only be able to select from appropriate procedures that the organization performs that are already going to lead them to success. If the appropriate CPTs are tied to that term, they may also be able to search by CPT code to pull in that appropriate term. And so really, again, all we're trying to do is create that connection and make sure that that is something that gets maintained over time. Type of things that we see, I think Shelley did a really good job of going into this. We see a lot of organizations, manually maintaining this data, and we'll see oftentimes a lot of duplicative procedures where the procedures really mean the same thing in the OR. Sometimes those procedures are mapped to the same codes. Sometimes those procedures may be mapped to different codes, and end users don't understand why that would be when they are in there using that data. We'll find a lot of coding errors. We'll find a lot of times where the procedure does not align properly to the CPT code. It does not align properly to the HCPCS code that it is currently mapped to, or it may also be mapped to too many codes. What we have found is that if you are looking at a procedure term and it is really, really broad, it's an overly broad term or an umbrella procedure where you're doing multiple things underneath one name, you may have to start assigning 5, 10, 15 CPT codes to that term to try to figure out, how do I get full coverage of this in my pre-authorization process? And oftentimes what that means is that term really isn't that good to schedule with. That means the surgeon really shouldn't be selecting it, and it likely should not be available for selection. Oftentimes getting down to a more specific term allows you to get much more targeted information, much more targeted CPT codes, and then can also be more targeted on the clinical side of things. It's better communication with the nurses so they know what preference card to pull, and they know how long a procedure is likely to take. We'll also find a lot of outdated procedures, inactive procedures, inconsistent naming conventions, all things that make it more difficult for organizations to run their surgical EHRs as effectively and efficiently as possible. So what do we do here? We do what we call IMO Core Periop. What IMO Core Periop really is, it's a database of surgical procedures, all of which are mapped to the appropriate codes. The way that this product works is that we work with organizations to take their existing surgical procedures. And we take every single way that you have clinically laid out those procedures inside of that dictionary, and we match those over to corresponding IMO Core Periop terms. An IMO Core Periop term always has a normalized naming convention and is mapped to the appropriate CPT and HCPCS level 2 codes that are necessary for pre-authorizing that term, for being able to search for that term appropriately inside the EHR, and potentially for billing that term on the other end. Really, the idea is we want to apply that level of standardization across the entire dictionary. Again, creating that connection between the clinical term and the codes that are necessary in the pre-authorization and billing processes. That way, you know that they are always lined up appropriately. Now, this is something that obviously you'd want experienced coders doing. And that's why we have people like Shelley and her team. And what they do is they maintain the linkages between our code sets and our terminology. Because we all know that none of this stuff is stagnant, right? CPT updates every single year, typically effective January 1st. And that's the type of work that we're doing to make sure that all of our clients' dictionaries are always up to date, so that their revenue cycles and their clinical end users can get the best possible outcome year to year. As we're going through that process, other things we're going to look at besides just the codes are also those other inefficiencies we've been talking about. We're going to look at where we see those duplicative procedures. We look at where we see those umbrella procedures where you're doing multiple things under one name. We help skinny those down, get you more specific terminology, so that at the end of the day, each term represents what's really occurring inside the operating room. And then, of course, again, it's mapped to those codes. And something that I always really want to highlight with people is that, this is not just about CPT codes. It is also about level 2 HCPCS codes. In working with our client base, what we have found over the past couple of years is that more and more payers are requiring these HCPCS codes to be pre-authorized. That's like your C codes here. We see it a lot with the S2900 robotics codes. Codes that allow you to easier identify procedures, supplies, products, and services, in addition to just the CPT code. We'll see it a lot with some more complicated implants, stent insertions, cochlear implants, things along those lines where having the HCPCS code available inside the surgical dictionary is just as important as having the CPT code. So the idea behind all this, right, it's kind of what I keep going into. It's about standardization and normalization of the process, making sure that all of your terminology is appropriate for your organization. You have standardized descriptions that use a consistent naming convention across the board. And then that it's all mapped to all of the codes that you guys need for your system to properly operate. We manage the updates of these codes as well. So CPT updating every single year. We, of course, will manage that CPT code update, and HCPCS with all of those level 2 code releases. We typically update our content 4 times a year to fit really well in with those processes that organizations have built around that. And really, again, so much of this is about how do we capture the financial data as appropriately as possible. A major thing that we do here as we work through these procedures is we work with organizations to make sure to identify all of their inpatient-only procedures. We have found over the years is that organizations really struggle to identify these up front inside of the surgical scheduling process. Many organizations are really reliant on seeing these afterwards, potentially when they've already gotten denied, when the patient's already left. So what we have done is we really work to make sure that we identify these based on the procedure and based on those CPT codes that our CMS identifies as inpatient only. And we actually work with organizations to put controls around that inside of their surgical scheduling system and try to flag that so that when they are scheduling that, if the patient is a Medicare patient, the procedure is an inpatient only procedure, and it's being scheduled for an outpatient location, you could throw a flag, and so that could be adjusted up front so that you're not seeing those denials later on. You can also use that to look at that at other spots. It could be when the surgeon is placing their inpatient order. You could put that even in the PACU in case, because we all know things change all the time inside the operating room. Procedures get adjusted. So maybe you changed it from something that wasn't inpatient only to something that is inpatient only. And you need to make that change in the system. You also want to have that flag there so that if you need to get that pre-authorization reworked, whatever work you guys need to do to make sure you're getting paid appropriately for those, you want to capture that as early as possible. So we put a lot of controls in there, make sure we're identifying all of those inpatient-only procedures, and then, of course, keeping that up to date as well, because that does also tend to update effective January 1st. In addition to that, we've also really started supporting site of service accuracy. What this means is we started working to identify procedures that can and cannot be performed in ambulatory surgical centers as determined by CMS. So a little different from the inpatient only. These typically are ASC covered procedures and ASC excluded procedures. What that means is we take those and we put that content, again, very similar to what we talked about with inpatient only, into groupers, and we flag those. If for organizations that have a mix of ASC locations and non-ASC locations, especially if you have people who are scheduling at both, that can be very difficult for them to understand if that's not placed in the system. So again, based on CPT code, we can place that in the system to make sure that if they try to schedule those in inappropriate locations, it's an ASC excluded procedure by CMS. Again, it's a Medicare patient, and they're trying to do that in an ambulatory surgical center. You throw that flag, and you can identify that up front and have that procedure moved to the appropriate location. So again, really just trying to align, how do we align the content in the dictionary to help people make the correct decisions on the site of service of a procedure. So shifting gears a little bit, another feature we do offer is patient-friendly terminology. These are translations of our content that are designed to be shown to a patient in places where they're going to interact with their own data. Things like my chart, text messages, email reminders, anywhere where a patient's really going to be taking on that work. And that's something I think that's also, we've had a lot of organizations start to utilize in other areas as well, including things like their financial transparency initiatives, where you want patients to have potentially more patient-friendly language to be able to search against inside of your EHR, so that you have, so that they're able to find those when they're doing those lookups. And again, you also really, for those financial transparency type initiatives, the CPT code mapping is really a critical piece of that as well. Because when you have those accurate CPT codes, that allows you to identify, okay, for this surgical clinical procedure, how much is each one of these codes actually costing? Again, you need that connection in place to enable and support those financial transparency initiatives. And so that's really what our product is, kind of the ideas behind it. The last thing I'm going to go into, and then we'll go into Q&A, is some of the value that organizations have seen by taking on this cleanup work, ensuring that they are hopefully helping both their clinical side of the house and their revenue side of the house by cleaning up the dictionary and ensuring accurate code mappings that can be used throughout the revenue cycle process. And so this is something that really, again, extensive impact across a lot of different workflows. We've seen organizations use this to help enable preference card cleanups, to help ensure easier physician scheduling, ensure better case accuracy by making sure each procedure really represents what's happening in the operating room, and then allowing the systems to do the calculations the system wants to do in order to calculate your procedure times. That when you are able to better understand what procedures are really being performed from a clinical perspective, it can also improve things like room and block utilization, which again have significant financial impacts on the organization. When you better understand how long a procedure is going to take, you could get more procedures in place. You could avoid overruns, you could avoid underruns that can cost $40, $50 a minute. From the rev integrity side of things, we always, again, really like to focus in on making sure that you have the appropriate codes available for pre-authorization, you have full coverage for those pre-authorizations, and that the coding is consistent throughout the entire workflows. We want to avoid any wrong claim codes that can lead to denied claims, that can lead to denied pre-auths, because that doesn't align properly with what's actually being performed. And so to put some numbers to things, we have worked with organizations. We have worked with an organization. They, again, the average loss per case for their inpatient-only denials was over $17,000. And so they were manually identifying all of their procedures that were Medicare and patient-only. And they were doing a good job. I mean, they only missed 25 cases in a year. But still, that resulted in over $400,000 in write-offs. And because of that high average write-off, we were actually able to work with them. We were able to get the controls in place and work with them to get this down to zero by identifying these up front and ensuring that they don't actually make it to the point where these are being billed and pre-authorized. Another organization we worked with, this one I'd say is a little bit more of a typical, but this is one that they saw a 57% reduction in their inpatient-only denials in the first year after going live with IMO Core Periop. Again, just getting those codes in place and getting those controls in place. So for them, it didn't immediately drop to zero. They had not scheduled with CPT codes before. But as they started doing that process, we saw a precipitous improvement every single quarter. And by quarter one, they only missed one case at 16,000 versus almost 1.5 million the year before. So that was about $3 million in reclaimed revenue from the year prior to that year alone. Finally, the last thing here is about case duration accuracy. So case duration accuracy, again, is really the measure of what percentage of your procedures are scheduled and actually take the amount of time that you scheduled them for. And when we look at that, again, really, really big revenue cycle implications, because each percent that you guys are missing in that, each time that a case is scheduled that and then goes over or goes under what you saw, you're either losing money in opportunity cost or you're overrunning your ORs and losing money there. And this really does come up a lot with surgical EHRs because they start doing these calculations for your clinical staff. And they do it based on the previous times that the procedure was performed. And so if that procedure isn't at a level of specificity that represents what's actually happening inside the operating room, those calculations are often rife with errors. And we'll see these percentages be really low at organizations, anywhere often from 45% to 65% of their procedures are actually being done within about 15 minutes of when they expected them to be. And so this is something where we've seen really big improvement with working with organizations and making sure that those clinical terms represent what's happening inside the operating room. And then they avoid some of that, that money that you really can lose. We've worked with an organization to create financial models around this, essentially saying, if you are able to better predict your cases, how much is that actually worth to you? And we used a very, very conservative financial model, but we worked with a system about a year ago to do this work, and they were able to identify about 109,000 minutes over a year that they were incorrect originally in their case duration forecasting. So essentially, when they were doing when you were looking at this, those are minutes that would have been either overrun or underrun minutes. And what we did is we took that and we took only 20% of that, because we know just because you save a minute here, you better predict what's going to occur with that case. Doesn't necessarily mean that you can utilize it. But we assume that about 20% of those could be utilized, and we know that the cost of an OR per minute averages out to about $43. So for them, that came out to a little bit under $1 million in value, just by, again, being able to better predict how long their procedures are going to take, and then operationalizing that by working that into their scheduling workflows, and their case ordering workflows. So that's really the content I wanted to cover with you all today. So just kind of some of the ongoing value that we want to talk about, really the big things. We help organizations clean up the surgical scheduling dictionary. We help ensure that there's always a connection between the codes that are necessary for revenue cycle and the clinical terms that are needed for scheduling purposes inside the OR and that are needed for clinical purposes. We help support the billing and reimbursement workflows by helping support those more efficient coding workflows, making sure you have all those codes inside the system itself, that connection between the CPT and the HCPCS and the clinical term, so that people aren't hopefully going to a sticky note that they put on their computer saying, this is the CPT code I use for this procedure. We want all of that type of information to always be living inside the system. We don't want people having to go Google for a CPT code every time or go to any of those other places outside of the system that they're working in on a daily basis anyway. And so, yeah, that's really what we are talking about today. Some of the key takeaways are just very simple. Poor surgical data can lead to a lot of revenue leakage and denials. When you don't have that file up to date, when you don't have that file as effective and efficient as possible, and doesn't align well with clinical and financial workflows, you can see significant problems. It can be hard to pre-authorize the procedures appropriately. You have CPT codes that are out of date, still living inside of those dictionaries. And so all we try to do is clean all of that information up so that things work as most effectively and most efficiently as possible. And so, Jordan, I think I'll turn it back over to you for any Q&A.
Awesome. Thank you, Alex, and thank you, Shelley. Yeah, so if you don't mind putting in your questions into the questions section on your panel or on the Zoom console, and we'll go ahead and answer. Just please excuse any brief silence while we look at everything. I see one come in, and it's either you or Shelley or Alex. So I think we received the MyChart patient descriptions of procedures on the last annual IMO codes update, but they now generate hard stops when we try to migrate ORP changes to Epic. The display value seems to be provided, but the display type is not, which causes the hard stop. Kiosk display name or online display name are the options for this field. Not sure if the display type is something IMO can provide for future import. I'm sorry.
Yeah, I'll take that one. Jordan,
Okay.
Jordan, are you able to follow up specific?
Yes.
Are you able to see who that specifically is?
No, but if the person that actually put it in doesn't mind writing me who it is, and then we can follow up.
Yeah, I want to follow up on that one specifically. The answer to that is, yeah, we can work with you to let you know how to fill out that field. That is an Epic field, specifically kiosk display name or online display name. And we'll just want to fill it all out all the way down that import and then import that in. So I'll have our implementation team follow up directly with you on the best way to do that.
All right, a few more. So we have issues with inconsistent naming, like the same procedure called 3 different things. Can this fix that without us rebuilding everything?
Yeah, so what we're doing in those situations is we want to take those procedures and we want to identify, okay, which ones of these do we need to actually maintain? We'll oftentimes see things where a procedure is spelled out in one location. Maybe it's an acronym, another part of the dictionary, and then maybe in a third spot, it's a completely different word order. We always want to identify which one of these is correct, essentially. Which one of these is the one that the organization wants to maintain moving forward. And typically what we want to do is inactivate the others and maintain only one moving forward with the appropriate name and the appropriate codes. And we can do that really pretty simply. For most EHRs, when we do this type of work, we don't change the actual record itself. We are aligning like procedures to like procedures. And so what that means is that there's not a ton of work that goes into that. Really, most of the work is in making the decision on if those are using different preference cards, which is the appropriate preference card to continue to maintain, and migrating that to the appropriate procedure.
Awesome. Okay, if we move forward, what's the lift for implementation?
So typically our implementation lift is anywhere from about 4 to 6 months. Really depends on what your starting point is and where you're trying to go, of course, with all of this content. But really, we're spending that first 6 weeks of that with all the work on IMO, taking your procedures, lining them up with the appropriate IMO procedures, and then when you're engaging your teams to make sure that we can identify each one of your procedures appropriately inside of the system. So typically that cleanup is usually about 4 to 6 months.
Got it. Okay. We've had claims denied for using the wrong code, even though it made sense clinically. How does this help with that?
Shelley, do you want to take that one?
Yeah, I can answer that. So when claims are denied for using the wrong code, even though it made sense clinically, this usually indicates a disconnect between clinical documentation and the specific coding requirements. So how we do that is we work closely with your team and the surgical dictionary and look at that procedure and what the surgeon is actually performing from that scheduling perspective, and then talk about what the code is from that perspective, and then looking at it to make sure that we're assigning the most appropriate code for that prior authorization, so that all of it is set from that beginning piece, so that the follow through to the operative report does have all of those pieces, and then the coder and or biller can still pick up any additional codes that can go along. But from that start, you have those appropriate codes on there, and it does start with that good surgical dictionary and having good naming and all of the pieces and parts. So again, approach, anatomical site, and all of those allow for good CPT selection and HCPCS codes. And our product does that.
Nice. All right. Another one came in. Is there a process of cleaning up the IMO library and the mismatched naming convention?
Are you talking about, if you're talking about content that's already in the IMO library, the answer to that is yes. We are always trying to clean that up. If you ever find inefficiencies and inconsistencies in the naming convention, we want to work with your client success lead. We'll of course want to work with our implementation team to make sure that we're cleaning that data up. We're also currently doing a full-scale review of a lot of our content to make sure that we're finding any existing inefficiencies to make sure that's all cleaning up as well. As we're migrating a new client over to IMO Core Periop, we're also going to we always try to really focus on how do we make sure that they are using a consistent naming convention. We, of course, always recommend using the IMO naming convention. Not every organization chooses to do that. Most do. Some organizations do choose to maintain some of their own names on some of their procedures or maybe some of their service lines as well.
Nice. Okay, looks like we have one more. So how hard is it to get everyone, clinicians, schedulers, coders, on the same page with this kind of setup?
Yeah, I mean, I think that when you have a standardization across like the naming conventions, when you have standardization of the clinical term to the codes across the board, it does become a lot easier to get people on the same page. The surgeons using the same terminology as the people in revenue cycles, using the same terminology as the op-time team. Now, of course, transitioning to that can be a bit of a painful process for some organizations, particularly sometimes on the surgeon end where they may be very used to certain procedures. We always recommend and we always will take old procedure names and make sure to put those as aliases for new procedures or for any new procedure names so that they're still able to be identified and found by old search fields and by the old search keystrokes, so that it's not harder for people to find things. But it does require strong governance from organizations to ensure that, from the top down, hey, this is the naming we're using because this is what's going to work for everybody across the organization, not just people in a particular area.
Okay, well, it looks like that is all for questions. Thank you, Alex and Shelley, again, and thank you to our lovely audience for spending your time with us today. I know there's a lot of other ways you can spend it. So we hope you found it insightful and useful. If you have any questions or want to learn more about IMO Health or IMO Core Periop, please feel free to email sales@imohealth.com or even email your clinical sales executive. Visit us at imohealth.com also for more information. We have a ton of blogs and different content on there, so you can learn more. So as mentioned earlier, we'll send out a recording in our follow-up email, and I hope you have a great rest of your day. Thank you again.